একটু ওকে বলে।
হ্যাঁ, Beauty start please.
Distinguished guests, speakers, esteemed colleagues, and participants from home and abroad, and participants already joining in Facebook Live and in Zoom. Welcome you all in international live webinar on safe practices in resectoscope, organized by Gynecological Endoscopy Society of Bangladesh. On behalf of organizing committee, I am Dr. Rani Roy, Senior Consultant OGSB Hospital and IRCs and Office Secretary GSB, and Dr. Asim Kumar Saha, Deputy Secretary GSB and Senior Consultant Norsingdi Shodor Hospital and renowned gynecological endoscopic surgeon in Bangladesh will moderate the session. And our scientific coordinator, Dr. Tanzeem Sabina Chowdhury. She's the fertility specialist and associate professor, Bardem General Hospital and scientific secretary, GESB, and Dr. Sharmin Abbasi. She is fertility specialist and associate professor, Anarkhan Modern Medical College, and deputy scientific secretary, GESB. Today, we are honored to have Chairperson, Professor Laila Arjumand Banu, a very dynamic personality, to share endoscopic surgical skill and knowledge to gynecologists and gynecological endoscopic surgeons of Bangladesh. And she is the president of GESB and president Peaceways Club of Bangladesh and president Bangladesh Perinatal Society and past president OGSB. Distinguished, we are privileged to the presence of internationally renowned speaker and expert hysteroscopic surgeon, Dr. Mounir Mostafa, who will share his knowledge, experience, and technical skills and expertise issues through his lecture in masterclass and share discussion in question answer session. Dr. Mounir Mostafa is endogynecology consultant, Jeddah Maternity Center, Cairo, and he is ISGE board member and RCOG associate, Ireland, and he was the hysteroscopic visiting surgeon and trainer previously also in Bangladesh, and he is the inventor of Pompino and inventor of MIS hysteroscope, Tantara, Germany. I encourage you all to actively engage, ask a question in chat box that will discuss during question answer session. May I now request Dr. Tanzeem Sabina Chowdhury to deliver welcome address. Dr. Tanzeem Sabina Chowdhury, please.
Thank you, Dr. Beauty, for your introduction. Assalamu alaikum, everybody, and good evening. Respected Chairperson, Professor Laila Arjumand Banu, President, Gynecological Endoscopy Society of Bangladesh, and the respected audience and guests from all over Bangladesh and abroad. I am Dr. Tanzeem Sabina Chowdhury, Scientific Secretary, GSB. Welcome you all to the very interesting international live webinar on safe practices in resectoscopy. Now, we all know that resectoscope is a specialized instrument which is used in hysteroscopic surgery to remove fibroids and polyps. To talk about hysteroscopy, we have among us a very eminent hysteroscopic surgeon from Egypt, and he is none other than Dr. Mounir Mostafa. He is a very renowned gynecological endoscopic consultant from Egypt, and he is also a very good friend of Bangladesh. Actually, he has visited Bangladesh before to disseminate his knowledge and expertise and technical tips and tricks in the field of hysteroscopy. So without further ado, this is my absolute pleasure to welcome Dr. Mostafa to start his deliberation on resectoscopy. So it is over to you, Dr. Mostafa. Please start. You can start your deliberation. Thank you.
Let us go to the lecture. Over to Dr. Mounir Mostafa.
Good evening, everyone. How are you? Many thanks for the Bangladesh Society of Endoscopic Gynecology and Professor Laila, Professor Sharmin, Dr. Beauty, Dr. Tanzeem. I hope my voice is clear.
It's perfect, sir.
Yes.
Perfect.
Thank you. Today we'll talk about using resectoscopes and of course the safety issues in using the resectoscope. We know that the resectoscopes is an advanced level of hysteroscopic procedures. It's not for beginners. Anyone using hysteroscope should have done, according to literature, we are talking about from 40 to 60 operative non-resectoscopic procedures using the regular mechanical hysteroscope. Okay, the resectoscope itself is a device inherited and modified from the endourology. Those they used it to make for the prostate resection. Their function in gynecological procedures is the resection to cut the tissue, ablation to make areas of hemostasis, and tissue dissection. Their use is almost all with electrosurgery. That's why they have some more complications, and that's why we need some more safety during using them. The original resectoscope we got from the urology is the one above. It's called active resectoscope. When just you leave it like this, you have the electrode coming out. Sorry. Okay, when then a modified one was done for the gynecology called the passive electrode or the passive resectoscope, where the electrode is inside and you have to push it to get it outside. There are some difference in the ergonomics of using them. The most important thing is that in the active electrode, you have more liable to break the electrode during working. So if you don't, if you are not well trained for the active one, we usually avoid it in gynecological surgeries. The common uses of resectoscopes is, of course, submucous fibroids, metroplasty, the large septum and the T-shaped uterus, endometrial resection, niche resection, remnants of products of conception, ectopic niche pregnancy. Large polyps are included, but they just follow the myoma technique or the myoma approach. Okay. What is the resectoscope? The resectoscope is a modified kind of hysteroscope where you have our telescope inside the uterus. The telescope, of course, we know it transmits the image and delivers the light. Then we have another part unique for the resectoscope called the working element. It carries the electrode, the working part of the resectoscope. It makes it moves in a specific range, not too far. It doesn't go too far so that we don't do distal harm, and not too near so that we protect the telescope, which is glass. Okay, and it delivers the electricity to the electrode. Then we have an the inner sheath, which gives the fluid in, and an outer sheath, which gets the fluid out. Okay, there are many illustrations for the design. The electrode has one, the resectoscope has one type of movement. It is much easier, in fact, than using the scissors or graspers or the office hysteroscope. You just get in and out. That's it. You push the electrode in, you push the electrode out. This is what the resectoscope it does. You can rotate the electrode. You can rotate the electrode by rotating the whole resectoscope. This is how we catch it. You have places for 3 fingers. The little finger is out. The index finger is the one in the back pushing the electrode. Okay, you rotate the resectoscope with the whole resectoscope. You rotate it on the camera. We don't have internal rotations. You just rotate it all. Okay, and you activate the electricity by the foot switch. So the hand catching the resectoscope just pushes the electrode in and out. We don't have any special ergonomics. Okay. The most important thing to avoid large mechanical thermal complications is to know and use the eyes before using the hands. If we always understand the image on the screen before performing the next step, you will never have large or big complications with the resectoscope. We have many types of the electrodes, but there are three main families. The first one is the resection, the loop, the resection, which scoops out, cuts out the tissue, like the ones we use in myoma. We have the ones, the needle or the knife, which cuts the tissue without removing tissue. And we have the ball electrode or mushrooms, which they make ablation. They coagulate or fumigate the tissue inside. What are the sizes of resectoscope we have? Now we have at least 5 main sizes of resectoscopy in gynecology. We have the same size we got from the urologist, 26 French, which is 8.6 millimeter. This one uses a telescope of 4 millimeter, 30 degrees. Then we have the 22 French. This is which is 7.3 millimeter. It uses the 2.9 millimeter telescope with 30 degrees. We have the 18.5 French, which is 6 millimeter. It uses the 2.5 30 degrees. We have the 16 French, which is called Gobini. It's 5.3 millimeter. It uses 2.900 degree telescope, and we have the 15 French Storrs resectoscope, which uses the 2.90 telescope. You have these three. They are called mini resectoscopes. We have now, you'll see now the difference in using mini resectoscopes versus regular resectoscopes. So these small three are called mini resectoscopes because they don't need cervical dilatation. But the last one, 15 French or 5 millimeter, this is the size of the office hysteroscope. So the last one is an office resectoscope, and this is very new and very game changer in the practice. We are here in these numbers talking about the caliber. You see the caliber of the maximum caliber of the outer sheath, the maximum caliber of the resectoscope itself. Okay, this is the Gobini mini resectoscope. You will see the loops. We have the 3 loops: the circular one for resection, the needle one or the knife one for cutting the tissue, and the ball one for the coagulation. Some time back, we had something called cold loops, Mazzoni cold loops. These loops, they are not electrical, they're mechanical. They are thick mechanical electrodes. They are called electrodes or loops, but they're not connected to electricity. We use them mechanically like this to separate the myoma, inoculate the myoma through the pseudocapsule, as you see here. There are 3 types. I don't think they are very common now because the shavers and the new techniques are there, and only Storrs is producing them. They are not very popular, but just to know that sometimes some uses of resectoscope, we don't need electricity. Okay. I think this is the only video you can find online for the cold loops. You see how the surgeon is moving. Everything is moving. You are just pushing the electrode inside. To change the loop during work, you have to get out the resectoscope, deassemble it, and change the loop. You can't just change the instruments, the loops, like you change the instruments in the hysteroscope. You pull it out and insert again the new instrument. You have to get out the whole resectoscope, deassemble it, put the new one, and then go inside again. Okay. As we said, the mini resectoscopes, the ones 16 and 15 French, they have 0 angle telescopes. This is limiting in the action because we can't like look at the sides without moving the telescope. But you can, this is for safety issue, that the loop is always in the center of the view. You see here, when you put the electrode, see the loop is always in the center of the screen. It never goes away. So when you finish the operation and you think you have a complication, you can just revise the video and you will never lose the loop from the view. On the other hand, you can't manipulate the view to the left and the right by rotating the hysteroscope like we do in the office hysteroscope. The view is always 0 degree in the middle. Because we have electricity, electric generator, and fluids and equipment, we have to set up the operation theater in a way that things doesn't get stuck with each other. You have the tower, the visuals, the screen, the camera on one side, the electric generator on the same side. You should have the fluid and the pump of the fluid on the other side so that you don't get fluids on the devices. And you have an operating trolley for the equipments and instruments beside you. All three should be beside you, but not beside each other. The surgeon is in the middle of the setup. You also don't forget the patient positioning. In this position, we have the uterus like this. Okay, you see the uterus is not horizontal. The uterus is nearly vertical or like 60 degrees with the ground. So when you insert a hysteroscope, it is going to hit this part of the table if it's not put right. Patient has to be put in lithotomy position with the perineum outside the table, and this space down stays empty. Okay, so that we avoid if the resectoscope hits something outside the body, it will hit something inside the uterus. You have to be free movement like this. And usually, because you see the direction of the resectoscope or hysteroscope, it's upward, so you will be catching it from downward, so you have to sit down to control for better fine control of the motor actions you will make. We'll have a fast review of the electrosurgery used. We have two types of current, the monopolar and bipolar current. At the end or during the surgery, what you need is heat. We don't need the electricity itself. You need the heat, but the difference between monopolar and bipolar is safety and cost. Okay, usually electricity goes in the circuit. We have two electrodes for any one, monopolar and bipolar. This electricity goes in the whole circuit, and it comes in the thin part, of high resistance. It changes to thermal engine. Okay, so in fact the electricity doesn't know where it is going to act thermally. So you have to create this high resistance point. This is monopolar. You have one electrode in your hand and the other is touching the patient somewhere. Okay, then the electricity passes from the electrode in your hand. It has to go through the patient and looks out for the outflow into back to the ground. The risky point here is that you don't trace the electricity. You don't know where is the electricity going. Maybe it goes through another outlet. If the patient is touching something metallic or an IV stand beside her, or the bed is metallic and she's touching, she can go there and induce thermal injury. Okay, you don't trace the electricity inside the body. The bipolar, you have the two instruments or the two electrodes in between your hands, so you are sure that the electricity goes from one electrode to the other, so I can trace the electrodes where they're going. But this one monopolar and this one is the bipolar. But the problem is in hysteroscopy is that we use fluid. We work in fluid. So before electrosurgery, the fluid we use is the saline, the normal saline, which is 0.9 sodium chloride. So what happens if you put electricity passing or two electrodes of electricity inside the sodium chloride? We will have electrolysis. And what will happen during electrolysis is that the current will pass through the fluid. We have no risk for the patient. We don't have risk, but we don't have thermal effect. The electricity is not working because it is not making high resistance. It's just passing everywhere in the fluid. So the other solution is to use monopolar surgery, monopolar current, and we use a fluid that doesn't conduct electricity, which is distilled water. But distilled water is very is very dangerous because the osmotic pressure is zero. So we put things that increase the osmotic pressure or oncotic pressure to decrease the intravasation. Most commonly, it's the glycine, 1.5% glycine, which is amino acid. So it has a high molecular weight, and it increases the osmolarity to around 190. We'll discuss this later. Another option is glucose, 5% glucose. It also increases the osmotic pressure of the fluid, but it doesn't conduct electricity, so you can work with a monopolar electrode. But still, they are not as safe as the bipolar current. So to use bipolar, we have to use a specific bipolar generator, which produces very high current, okay, that overcomes the capacity of the normal saline in the uterus to conduct electricity. So for the normal devices we have, this is it's about 100 up to 100 watt of power. For the bipolar hysteroscopic or bipolar under saline current, the devices starts from 300 watt power. Okay, of course, bipolar is the safer electrosurgery itself, safer distension media, cheaper distension media, more suitable for office setting, but it has more expensive equipment. I don't know if in Bangladesh it's allowed to use monopolar or not, because I always see bipolar when I come, but in Egypt I use monopolar. This is how the bipolar looks. This is the 15 French stores resectoscope. You see how the electrode looks. One, the red arrow, this is the electrode one, and the blue one, this is the return electrode. So there are two pathways for the current. It goes inside till the electrode, the round part, and then it goes in the saline, it cuts the tissue and comes back in the other road. Okay, there is no ground plate. Also, when you use monopolar, make sure you use a good patient plate, because if you have problem with the plate, you increase the risk of burns, distal burns in the patient. Maybe you can use the dual split, which will not work unless it's contacting the patient with a good surface area. Okay. In hysteroscopy or resectoscopy, we use only the cutting current. Whether in bipolar or monopolar, we use only cutting. We don't use the coagulation, because cutting current is with less heat spread. Coagulation depth of heat spread is 5 or 6 times more, and this makes more damage for the collateral endometrium and for the other organs if you are working near the bladder, in the niche, or near the abdomen or intestine in other place. This device is a bipolar under saline. Okay, you see it's RB 300. It starts with 300 watts. That's what we need for a bipolar under saline. Talking about fluids, we have to know that the most important factor related to complications is we have a lot of things: operating duration, distension fluid type, operating pressure, fluid input, fluid output, total fluid output, type of anesthesia, clinical signs. But the most important is you. It is how you are aware of the risk of the fluid and how you are managing it synchronously, not managing the fluid problem when it happens. You have to be very active with the fluids. You start first before the problem. Okay, this is the comparison I was telling you now. This is the normal saline. It's distilled water and 0.9% sodium chloride. Osmotic pressure is 290 milliosmolar. Blood serum is 300, so it is very near. Distilled water is 0. Glycine is 1.5. Glycine is 190 milliosmolar. In literature, we have glucose, 5% glucose as distension media, and most of the applications, and this is very interesting, most of the applications of this is from Bangladesh. And it's not gynecology, it's urology, urosurgeons, and I use it for evidence because many places I go, I don't find glycine, and I tell them, give me glucose. Then they said, we don't know this. I show them the publications from Bangladesh. They use glycine, glucose instead of glycine with the same outcome of safety. So the normal saline is a standard medium to be used every time, but if you only have monopolar, then you use glycine. We know that glycine could make hyponatremic hypervolemia, which is left untreated. You will have lower levels of sodium levels, and this will start from restlessness, nausea, headache, confusion, arrhythmia, convulsions, up to coma and death. So this is the big risk of hypotonic or atonic fluids. How we deliver the fluid during the surgery? We have the first thing, the gravity fed containers. This is also inherited from urogynecologists, urosurgeons, where you put the 3 or 4 or 5 liters bag 1 meter above the pelvis. This gives a pressure of 70 millimeter mercury. But this is totally unadvised when you use resectoscopes. In the resectoscope, you have an advanced operation. You need very good distension and very good control of the fluids inside the uterus. Of course, also you have the manual pumps with compression cuff, but this has to be with the pressure gauge. You have to read. You see here, this is the pressure. You have to know what is the pressure inside the uterus or inside the pumping pressure. But this requires dedicated personnel. Someone has to stand to operate, to manage the fluid. So ideally, we need a pump with adequate amount of fluid delivery, suitable pressure, monitoring and controlling the pressure and outflow, and it would be better if you can monitor the deficit. This is an automated pump like the ones you have. Here you control the amount of fluid going in 1 minute, and you control the pressure at which the pump stops or the maximum pressure you need. Also, there is automated fluid management system where you collect the outflow, you collect the whole fluid coming from the operation, from the resectoscope, from under the patient, from the floor, and you weight it against the fluid used. It's going to give you the deficit. But usually you can do this manually. The most dangerous complications of hysteroscopy are related to distension media, which are fluid overload and air embolism. So because the resectoscopic operations are long and you need a lot of fluid, we have to know that what is the deficit. Fluid deficit is with saline, with normal saline in healthy women of reproductive age, you start to monitor or you start to think about a risk starting from 1 liter of deficit. 1 liter of deficit or 1,000 milli of deficit, not 1,000 milli of usage. That means you pumped like 4 liters, you collected 3 liters out, then you have one deficit of 1 liter. Then you start to think. You don't stop at 1 liter. It's okay. The patient, if it's young, healthy woman, it's fine. You can have to 2.5 liter. Okay, at 2.5 you need to terminate. For me, I don't wait 2.5. 1.5 is more than enough. Okay, there are some tricks I'll tell you later, but for 1.5, I don't leave the patient to go into the gray zone or to the red lines. I don't have to stop like 2,490 millimeters. This is not safe. You always have to be far from the risk. If the patient is, if you are using glycine, or the patient is old, or she has comorbidities like cardiovascular, renal disease, then you make this 750 milli, okay, less than 1 liter. If you have deficit of 750, then you stop in these situations. how do you know the deficit? Because you can't like every 1 minute or every 30 seconds you calculate what you used and what you get out. There is no evidence of the optimal monitoring, but I usually do it uh, in literature. It is 10-minute interval, but for me this is too much, because in 10 minutes you can use up to 2 liters of fluid. So I do it every 1 liter of inflow. If you put the saline, you used 1 liter of saline, someone has to calculate the deficit. Okay, while we are working, you don't have to stop to do this. In glycine, every 500 milli, or if you know your inflow rate, it's you make the inflow rate of 250 milli per minute. So 1 liter of glycine, I use it in 4 minutes maximum. So I can do it every 2 minutes, just to calculate, someone calculating the inflow and outflow and telling me what is the fluid inside the patient. Operating pressure is very important. You see here that if you have intrauterine pressure from 20 to 150, for example, the fluid absorption increase. But after 150, the absorption increases so much, exponential increase. So you should always keep the pressure as low as you can, okay, without compensate, without spoiling the surgery itself. So what I always do, I use 140, 130, 140, 150. This is my average for the operations by default, unless I need something else. In the office, it's sometimes lower, okay, so that the patient will have less pain. What's written about air embolism is that it is by air bubbles in the fluid system, frequent reintroduction of the hysteroscopes itself. You remove the hysteroscope and put back, so you do like piston effect. You push air inside by leaving the cervix and the vagina open to air, or patient in cylindrical position. In fact, I never saw this. I revise all the complications of hysteroscopy here in Egypt. I never saw this. Air embolism, what I saw, it is when you have fluid overload, or you use the manual pump without gauge. You don't know the pressure, you don't know the flow, just pushing air and fluid with the manual pump. So you should always have a fluid management plan. When there is a big operation, when you have like diagnostic missed IUD, polyp, I don't use a fluid management, just because you only will use 1 or 1.5 liters of saline. But when you have a big operation, we have to make fluid management plan before the operation. We have to announce the type of the operation, the type of the media we'll use, the operating pressure, the fluid input and input rate and amount, the gross output, the type of anesthesia, the operative progress, and the timing of the operation, and the clinical side. You should always have the attitude of, I will stop anytime. We don't argue with the stopping in hysteroscope, because the time you refuse to stop, okay, you will have another problem telling you to stop. If you fail to plan, you plan to fail, and it's always safe better than sorry. I don't mind doing it. I tell the patient, I can do this if you have like 8 centimeter myoma. You usually do it. I tell her I usually do this on 1 time, but if I do it on 1, 2, 3 sets, okay, this is the safest for you, not for me. So you have to be this very easy with the stopping during the work. This is I like this drawing. This shows how you all the time trying to balance between performance and safety and time, and you have to stop and finish the operation in the right time before falling into the sea. So as a plan, we have to use the appropriate distension media and delivery system. Sometimes in my center I have only monopolar, but when I have very big myoma, I ask to bring bipolar for this operation, because I won't use saline, not glycine. I know if I use glycine, I will have more risk for the patient, and I will have more probability that I will do another set for the patient. Keeping operating times to minimum. We don't play inside the uterus. Yeah, it is sometimes funny, but we don't waste time, because time means fluid and fluid means risk. Keeping fluid pressures under control. I know my pressure. This is very important. I know my pressure when I'm working, then I can decrease the pressure. Meticulous accounting of fluid balance. Anytime in the OT, I have to ask how much fluid did I use? Someone has to answer directly. Monitoring the total inflow. The procedure must be abandoned if the deficit rise upper limits, or if there is evidence of venous congestion. The complications is just like the regular complications of the hysteroscopy. You have to put urinary catheter, fluid resuscitation. You have to stop the fluid if you have complication with the fluid. Then you ask for the labs you need. You have clearly to terminate the operation. You call everyone, multidisciplinary team, and this is a grade 1 or a high emergency. Everyone has to come. But in fact, your role as a gynecologist is very limited in managing complication of this type. Okay. Now we'll go back to the resectoscopes. As we said, the common uses of resectoscope is submucous myomas, metroplasty, endometrial resection, niche resection, remnants of products of conception, and niche ectopic pregnancy. Let's see what are the options we have for every kind of operation. For the submucous myomas, now we need the largest resectoscope, because if you have small size resectoscope, then you will take more time doing the operation. More time means more fluid at the end, and this sequence, So for a submucous myoma, you need just to remove the biggest amount of tissue in the least amount of time. So you need the largest resectoscope, and you need the resection electrode. For the metroplasty, we have central metroplasty, the septum. You need a middle resectoscope. Okay, you don't need the large one, because the large one you have other type of complications, which is the dilatation itself and the amount of fluid going through. So you don't need the large resectoscope. You need the small the middle resectoscope. And you need the knife, the knife which is right angle, or the needle, not the resection. For the lateral metroplasty, you need the smallest. Why we didn't use the smallest for the septum? Because the septum is vascular. You will have bleeding, and you need to stop this bleeding by the electrocautery of the electrode. So you need the bigger one. But for the lateral metroplasty T-shaped uterus, you don't usually have bleeding at all. So use the smallest resectoscope with the knife. For endometrial resection, it looks like the myoma. You need the largest resectoscope, you need the resection, and you need the ball electrode. For the niche resection, no, you need the small one. Okay, because the niche inside the cervix, you don't want to dilate the cervix and alter the shape of the niche. So you have to go with a mini resectoscope to work, and you do the resection. Ideally, you should use after this a ball electrode, but I do the resection and the coagulation with the resection loop. Recurrent remnants of pregnancy, you need also the largest, because you will have an element of blood inside and you need to wash very fast. You need the large telescope to see the picture very good, because you have a lot of tissue and blood inside. Okay, so you need the largest and the resection loop. Many times you don't need the electricity in the resection. You can just do it like a visual curettage. Okay, when you have tissue fibrosed or deep tissue of the conception, then you need to activate the electricity. Niche ectopic, you also need the largest, because of the bleeding and the view, and you need the resection electrode. This is just a general scheme of what we will do. And if you have the options of many resectoscopes, but if you have only one resectoscope, then you will have to use it in all these operations. Okay. What is the advantage of the many resectoscopes? Because the many resectoscopes are new in this field. If you have a virgin patient, you can't go with the large one. This is going to be very difficult. No cervical or no cervical anatomical distortion. If you have cervical pathology, like cervical polyps coming out from the hymen in the virgin, this is very common, or the niche surgery. If you have a mini surgery of remodeling, T-shaped uterus, niche surgery, you don't need a big resectoscope. You just need you are in to do very small, fine thing, less potential complications, and it could be done in the office. See if you see the difference between the resectoscope. You see the big resectoscope. It has an important functions in things like big myomas and endometrial resection, but the mini resectoscope has another function for fine surgeries. Okay. Now we'll start with some operations and say, this is myomectomy. This is FIGO 01, myomectomy, 26 French. Cutting current here is 45 watt, fluid, glycine of course, 250 millimeter per minute, 130 millimeter pressure. Okay, this is the technique you use the resectoscope. You have to have the clear view. Okay, you have the electrode. Now you push the electrode, you go inside behind the lesion inside, you catch the lesion well. You push the resectoscope towards the lesion, then you activate the electricity. You don't see the lobe, the electrode, you don't see it during its cutting. It is cutting inside the tissue, you don't see it. And you never stop the current when you don't see the loop. You have to go in, because if you stop the current, the loop will get broken inside the tissue. When the electrode comes to you back through the tissue and you see it, you stop the current. Okay. Now here you should be very fast. Part by part, you go in, you go in, you go in, because we are using fluid. We don't stop unless we need to assess. When I find myself, I don't know what I'm doing, what is left, or where I am, I need to stop. But otherwise, I see the myoma in front of me, I go with continuous resection. Everything has to be clear. Okay. Now, this is anterior wall to the right, something like 11 o'clock. The pedicle of the fibroid is at 11 o'clock. You see, we didn't make any rotation with the resectoscope. We are doing only one movement. You go in, you open, you push the electrode, you go inside the myoma or behind the myoma, you activate the electricity, start pulling the electrode towards you. How do you pull the electrode? Mainly by the thumb. We are getting the thumb back, not the whole resectoscope. I'll show you when to move the resectoscope and when to move the thumb. Okay, maybe you can skip. Now you see we start when we finish, we get near to the myometrium, we have to know where is the myometrium and where is the myoma. This is by identifying the pseudocapsule so that we don't harm the. Now you see, this is the pink one is the one I'm touching. This is the normal myometrium. You go inside the pseudocapsule to get the myoma out. Is the 45 watt here good enough or less than enough or more than enough? This is what we do. You look at the color of the tissue. It has to be like this. If you can't find any brown or black, then the current may be very weak, and this could break the electrode. If you find charcoaling, all the tissue is black like coal, then this is very high current. It's dangerous, and it also may break the electrode. This is very good current to use. We have this one. This is the same thing, okay? But here the myoma pedicle is at 9 o'clock. Okay? the same thing. We are moving electrode in, electrode out. Okay. Also, you will find some bleeders. We don't stop for the bleeders are inside the myoma. I don't coagulate them. I just go continuing because you remove the whole vessel later. Okay. You have always to look where I put my electrode, but I'm not. I don't see the electrode here. I'm pulling, and getting all it out. Okay. Here we have something different. Now look. When we finished, we have this part of the myoma loose. I see that better than cutting it into pieces, you just go and separate it uh, uh, from the wall. So see how the separation goes. This is called backhand. This is advanced procedure itself. We shouldn't be doing it. That we see the electrode, we activate the current while pushing, not while pulling. Okay, you see how we do. But here we don't pull when we push the electrode. We push it towards the cavity, not towards the myometrium. You see, you activate and the electrode is pulled down while separating the myoma, not going into the uterine wall. The myoma, when finished, you need to go with the ovum forceps or myoma forceps now, and you get it from inside the cavity, the remnants. This is septum. Now this is the 16 French. This is the Gobini mini resectoscope with the cutting electrode, monopolar, 40 watt, 250 millimeter and 150 millimeter pressure. Here the pressure, I increase the pressure a little because in the septum with the small resectoscope, sometimes you need to stop the bleeding by pressure, not by the electrode. This electrode is very small. That's why even the pressure, the power is 40 watt, which is this is the lowest limit you do. Okay, now this is zero telescope, 2.90 telescope, so we don't have rotation. Also, I prefer to move side to side, not pushing the electrode inside the tissue. Okay, every time you see the this ostium, and that is the left and the right ostium. For every cut you see, you go now you see the right ostium, you see the left one, you go from left to right, left and right of the patient. Okay. Now, when you reach deep inside the septum, you will find that you will have some bleeders. The weakness of the mini resectoscope will start to appear. That's why I prefer using the larger one. But it's fine for thin septum and this. And if you have only one, if you have one type of the resectoscope, you have to use it for all. This is not an option. See? Now the whole operation took 4 minutes. The whole, not the one, the whole one. It took 4 minutes. With this flow rate, how much glycine did we use? 1 liter of glycine, 1 bottle of glycine. So 1 bottle of glycine is very safe. I don't need to make special measurements because you can never have more than like 30% of the fluid used inside the body. So for 1 liter, maximum you'll have 200 milliliters of glycine intravasated deficit, which is very safe. So we don't need to do. But if the operation, like said, 30 minutes, then we'll have 6 or 7 liters of glycine. Then we need to have very good measurements. Okay. We know that we have to stop before reaching the interostitial line and this. This is the 18.5 French resectoscope. This is also septum. This is a 30-degree 30-degree resectoscope, 45 watts, 250 millimeter mercury. I'm talking 50 millimeter per minute. I think this is the standard. 130 millimeter mercury. The same thing. It's only here to see if you have the 30-degree telescope. You see the electrode is getting to one side of the view. It's not in the central like the last video. Okay. I'm skipping because now you have very little bleeding. Okay, because this electrode is bigger, somehow bigger than the other one. Then we have a bleeder. We don't, in the septum, we don't reach the interosseous line. We have to stop before reaching the interosseous line. This is much safer and much better. Now, for the niche resection, this is the 16 French. This is the Gubini. We need a higher current. This is a 0-degree telescope with the round resection loop. I usually raise the current because the fibrosis around or inside the niche. Okay, sometimes if you use low current, you break the electrode, and this electrode is very smooth. What you do here is that you have to stop. You go inside the cavity, then you have to go back to see the niche, and you stop with the resectoscope in the cervical canal. You go with the electrode inside the niche, and you start removing small part by small part. This is why you need a small resectoscope, because if you use a big one, you will remove large amounts of tissue that you don't need to remove. Again, only cutting current. We don't use coagulation current. Even when we want to make hemostasis, we use cutting current on the electrode. We put it on the artery or in the sphincter, and we activate the current, the cutting current. No coagulation. Here we have the resection. Ideally, we make the resection, then we go with the ball electrode and make fumigation or coagulation for the floor of the niche. But here we will make this coagulation using the same electrode. You see the infected and the inflamed tissue inside the niche. Now this is, I use it here in this part like ball electrode. I'm not removing tissue, I'm just making coagulation. The other side, the same thing. You see, you go inside the loop, you hide the loop inside the niche, then you start cutting. You see the inflammation and the secretions. We keep on doing this until there is no any hidden parts inside the, the cervix. here we don't have high risk of fluids because we are not going into deep tissue. We are working in the cervix. We don't go inside the myometrium. We don't have a lot of large vessels opening. The operation itself, we don't need high pressure because we are already inside the cervix. So this is a low risk or relatively a low risk operation. Now for the big problem, with the biggest operation, the endometrial resection. You will have here to resect every part of the endometrium all around the uterus. There was a very good question about the strategy of what we do. So there are three things here to do. The first thing is the strategy of the plan inside the cavity. You start from down. What is the problem? Is that the problem if you start from up, you will have a lot of resected material getting on the posterior wall due to gravity. Then when you go to the posterior wall, you will find difficulty in work. So what you do, you start from downward. You start 6 o'clock, then from 6 o'clock you go to 3 o'clock, then you go to 9 o'clock. So you finish the posterior half first, then you go to the anterior half. This is much easier than starting with the upper thing. The fundal part, we don't have different separate fundal part. If you go with the resectoscope to the fundus, you can get the fundal endometrium from down and from up, just like the anterior and posterior wall. We don't have a fundal part that needs separate technique to remove. That was a question of how to remove the fundal endometrium. Then after this resection, we use the ball electrode. The other thing is fluid. Now let's see the ergonomics here. To take a long slide of this tissue, when we put the electrode, we don't push back the electrode only. We push back the electrode and the whole resectoscope. We make the electrode get the largest pipe. See, you put this, you come back with the resectoscope, and then with the electrode. So you get very long resected tissue. Okay, maybe I'll have a video later on how to do it, but we don't have a video now on how to do. Yeah, move the resectoscope and the electrode in the same time. The third thing for the fluid, there's a trick I use. If you use like 3 liters of glycine, you didn't reach the deficit. You're using glycine or saline, or you think that you still need more fluid, but the patient is near the limit. You stop the operation. I stop the operation. I tell the anesthesia I need diuretics. Sometimes I give methergine. Okay, I put urinary bag, and I stay 10 minutes, 15 minutes, calculating the outflow of the urine. When the patient gets like 1.5 liter of fluid, then you subtract this from the deficit. Okay, when you stop 10 minutes, you give the patient diuretics. She is losing fluids. Now the deficit is much less than this. Then you can start again. In this 10 minutes, the uterus also contracts. You will have less intravasation and less bleeding. Okay. Then when we finish, we go with the ball electrode and we remove any parts of endometrium if you see, but we don't usually go out with the resectoscope when we don't finish endometrial resection. You see here the view is clear. It is clear when we did resection and where we didn't, but when you go out and go inside, the different view is not very clear which part is resected and which part is endometrium. Okay. When I change the ball electrode, I raise the cutting current because the ball electrode has a very big surface area and it is not going to work with the cutting with the current of 60 or 70 watt. I make it 90 or 100. I don't know if there's any manual or recommendation about this, but I make it very high because this is very the surface area is big. Okay. Now this is niche ectopic. We have, what do we do in the niche ectopic? It's 2-step operations. If you have something like this inside the niche, we remove the pregnancy, and we have to, of course, repair the ectopic. Most of the time during removing the pregnancy, I don't need electroscopy. Okay, but this is the big resectoscope, because if you have bleeding, the small resectoscope will not have a good view and will not have a good control of the bleeding. This one, we don't have I'm not using electricity here. This is curate, just using it as a curate, very soft curate. But I would do it with the big resectoscope, this one. Okay, you see the pregnancy, the gestational sac is out, and now you have the niche. You can just do the niche like any regular niche. Okay. Now, when I do a resectoscopic operation, this is different from simple hysteroscopic operations in the preparation, because I can do an office hysteroscope with a patient who doesn't have a CBC or INR, PT, and PTT, this coagulation profile and this stuff. But I would not do it in patient. I would not do resectoscope for myoma in patient who doesn't have a blood coagulation profile. So the patient has to be properly prepared and informed. The anesthesia has to be informed that this is a long operation or this is an invasive operation. My anesthesia, he knows my work. So when we have a patient, we have three categories of the patients. We have, he calls it a smile. It is diagnostic missed IUD polyp just 5 minutes, or a regular operation up to 15, 25 minutes, or it's an overnight operation. We are staying like 3 to 4 hours doing large, deep myomas. So I don't know on what basis he classified this. Of course, this is his experience, but he makes a special thing for every one of these. So I have to tell him before the operation that this is a long operation, this is a short operation, this is a very short operation. You have to have a hysteroscope without dilatation at the beginning of the operation. If you have an intrauterine myoma 5 cm, you will do it with the 26 French resectoscope. You have to insert a hysteroscope diagnostic without dilatation at the beginning. Sometimes even me, I will go with the resectoscope. I will dilate and go with the resectoscope. Every time I regret this. Many times you have complications during dilatation. So you didn't even go inside the cavity and you have a complication you don't know. The hysteroscopic diagnostic procedure itself facilitates the dilatation itself later and ensures, of course, the diagnosis. Sometimes you have a patient referred FIGO 2, FIGO 1 myoma 3 centimeter, and you go inside the cavity and you find nothing. So you don't have to dilate and bring the big resectoscope and open the glycine and go inside, then you don't find anything. Also, you have to do diagnostic to examine other anomalies. Sometimes there is a myoma, but there is something else. There is a septum, but there is something else. So you have to check everything before using dilator and the resectoscope. We have to monitor the patient for immediate complications and then follow up for 2 weeks and 1 cycle. It's a teamwork. I can do diagnostic hysteroscope alone in a place which is not prepared, but I can't do a resectoscopic operation without the full team aware of what I'm doing and helping me, everyone with his task. There are some other complications related to the resectoscopes. Perforation. Perforation happens during dilatation during the operation. During the operation, it can be mechanical, it can be thermal. We talked about the fluid complication. The perforation during dilatation, it happens with good surgeons more than the ones with the resectoscope, because you know how to use the resectoscope, but dilatation itself has complications you can't always uh, avoid. So I don't have perforation using the resectoscope, but I have I have the dilatation, perforation during dilatation. So this what we do during this. I see if the dilatation is inside the cervix, and I can go inside the cavity without the fluid escaping into the abdomen. I sometimes complete the operation. Otherwise, I terminate the operation and do it after 2 weeks. But two cycles. So, but if you have perforation with the resectoscope itself, then you have to stop immediately. Okay, if it's mechanical, that means the resectoscope itself pushed the uterine and caused a perforation. You have to stop, monitor the patient for bleeding. But if the electrode made a thermal perforation while working with the electrode, the electricity was on, and you made a hole inside the uterus, you have to have a laparoscopic or abdominal look, because this you are near the intestine, and most of the times you will have injury outside the uterine cavity. Another complication that it is not common, but it is very annoying: electrode breaking. If you have the broken electrode inside the myoma or inside the myometrium, you cannot get it out with the resectoscope. Sometimes you have to go with the hysteroscope, mechanical hysteroscope, and grasper to get out the broken electrode. Thank you. This is the general scheme of the topics today. And I think we have more to say during answering the questions.
Thank you, Dr. Mounir. What a
Thank you.
excellent presentation. Your skill, technical expertise, and your knowledge all is mixed together in your lecture. And how time flies, we cannot understand. And really, it will benefit. Although it's an advanced procedure, I think for most of our gynecologists, but it will really help. Thank you. Thank you, Dr. Mounir.
Thank you for hearing. Thank you.
Now I ask Dr. Sharmin Abbasi to take comments from our chairperson, Madam, Professor Laila Arjumand Banu. Thank you.
Thank you, Dr. Beauty. Laila, Madam, due to procedure of the Madam health issue, Madam is not joined now, but we can take the comments of Madam. It is recorded comments. I'm requesting Renata, would you please play it?
Respected members of the organizing committee of hysteroscopy of Gynecological Endoscopic Society of Bangladesh. Good evening. Actually, I am sorry that I could not present in this masterclass, as I am timely, as I am in United States. Actually, I am, first of all, I welcome Dr. Mounir Mostafa, a legend of hysteroscopy and a very expert person. He, about 2 to 3 months ago, also organized or conducted a workshop in our country, Bangladesh. So again, I welcome again Dr. Mounir Mostafa, very nice person, and our participants enjoyed his learning curve and also the operations. So I think in near future we will also arrange another workshop, and he will conduct the workshop. Actually, hysteroscopy has truly revolutionized the field of diagnostic and operative gynecology. It is presently regarded as the gold standard method for both diagnostic and treatment of intrauterine diseases. Hysteroscopy was first revolutionized or invented in 1869 by Pantaloni by using the cystoscope from urologist and to diagnose a case of postmenopausal bleeding. And ultimately, it was diagnosed as uterine polyp. So it was also a revolutionary matter because without any incision, the operation can be done. No anesthesia, sometimes no anesthesia and hospitalization. Subsequently, the distension media is developed and by Rubin in 1925 and optic lenses in 1979 by Nietzsche. So these are all that gradually it is nowadays recently it has been developed or the hysteroscopy developed into a smaller, more flexible hysteroscopes, high definition cameras, and new methods for uterine distension and tissue removal. And ultimately, now we use the office hysteroscope, which is a wonderful procedure. You can do this operation in office setting and a clinic setting without any anesthesia and hospitalization. Every surgery has complication, though the hysteroscopy is uh, relatively less complicated than laparoscopy, but there are some moribund complications like, first of all, the perforation, hemorrhage. Uterine perforation actually occurs in a menopausal patient. So when there is hysteroscopy done in case of menopausal patient, caution must be taken so that the perforation does not occur because the uterine wall is thinner and fragile. Also, there is another complication like fluid overload, which ultimately leads to pulmonary edema sometimes, which is also a very dangerous complication. And infection is also a complication. So, before starting the hysteroscopy procedure, one must have meticulous, organized training and also should have the very good logistics support, which has the backup support. So, one should not compromise the quality of the instruments. I wish our participants will learn more with this masterclass, and also some video clips will be shown, I think, and they will be benefited with this modern technology and modern management of complications in the procedure. So Dr. Mounir Mostafa, also very always a smiling person and a very experienced person. I think he will again mesmerize our participant, and I think he will also love to talk in this platform. So again, I welcome Dr. Mounir Mostafa, and thank you very much. Sorry, I again cannot present in the exact time of the masterclass.
Thank you, madam. We asked question from the Gynecological Endoscopy Society of Bangladesh members and our EC, and we got many questions. Dr. Asim will conduct that. Before that, chat box has 3 or 4 questions. I just take it for Dr. Mounir. One question about actually the use of the fluid or media. Some wants to know about if we use the monopolar, which media or which fluid is more suitable. If we use the bipolar, which media or which fluid is more suitable. So Dr. Mounir, would you please comment on it?
Yes, sure. Thank you all for attending, and many thanks for Professor Laila for her presence and support of the webinar and the support of her colleagues. She's a role model for every one of you. Yes, if you don't have bipolar electrode, then if you don't have bipolar generator or bipolar resectoscope, then we use the glycine. This is the standard. If we don't have glycine, we can use glucose, 5% glucose. But the point we have to do is we should never ever use distilled water.
Okay.
Distilled water,
Yeah.
why we don't use distilled water?
Sharmin.
Distilled water has another problem, that when it goes into circulation, it makes hemolysis. And this goes very fast and unnotable unless there is a big complication that is irreversible.
Dr. Mounir,
Okay.
Dr. Sharmin, I have one question, Dr. Mounir. Dr. Mounir, just to my surprise, or to my surprise, I have seen that you are advising to use the bipolar. That is more safe. And 2 days before, Dr. Osama Salki sir, he was also in favor of doing surgery with bipolar. Both of you are using monopolar in your setup. Why? Why the difference? So you are using monopolar mode, but you are advising to go with bipolar. Why? Is there any specific reason?
Yes. This is, yeah, I heard him. In fact, and it is because people come and ask me in my place, why you use monopolar. The point is, if I work in my place 5 days a week, and 2 days a week I work other places. Okay, if I used bipolar in my place, the other 2 days I sometimes mostly go to places where they don't have bipolar generator. This, you can't move this one. You can move everything, but the bipolar generator is very big thing. Okay, so if I'm not well expert and use the monopolar passively very easily, you will have a problem. If all my work is bipolar, then I will forget how to use the monopolar. So it is easier for me to stay on the monopolar, to work anywhere. And when I have bipolar, it becomes easier. But if you work bipolar all the time and you have then monopolar, it becomes more difficult.
Okay, thank you, sir. Dr. Asim, the one or two question I'm taking from the chat box. By this time, if any senior madam wants to add anything, please, madam, add. Sir, another question from one of our hysteroscopic surgeon who works outside Dhaka. She wants to know what is the advantage to use a 0-degree telescope during septum resection? And at the same time, another surgeon wants to know the principle of doing hysteroscopy in Asherman syndrome. So both together, you can give the answer.
Yes, we don't have advantage for the zero, because this is a design of the hysteroscope. If you put a 30-degree in the Gobini or in the 15 French, you will not see the full view. Okay, due to the small size of the resectoscope, you have to use a 0-degree. So there's no advantage, but the advantage is in the mini resectoscope itself. It is a small. You don't need dilatation. You don't need to catch the cervix. You can do it in the office. This is the advantage. But you can't do this with the 30-degree telescope, because it's not going to work in this resectoscope. So you don't have a choice of the telescope. For the Asherman, this is a long question. If you are talking about the intrauterine adhesions, yeah, you have, of course, a rule of the of hysteroscopic intrauterine adhesiolysis, and preferably this could be done mechanically, not by the resectoscope, because using the current, any kind of current, bipolar or monopolar, inside uterus with adhesions could affect the little amount of endometrium left. But when you have Asherman means amenorrhea with intrauterine adhesions due to obstetrical accident. This is the full definition. So if the patient's amenorrhea, me in my practice, I don't touch the patient unless I have evidence that there is endometrium, because most of these patients, they have lost all the endometrium. Especially if she has long-standing amenorrhea, multiple trials of hysteroscopy or other operations, then there is no endometrium in the uterus, then the hysteroscope will not be beneficial. But if you find islands of endometrium, if you give hormonal and you find thickening parts in the endometrium, then you can go with the hysteroscope. Otherwise, I didn't see a patient with no endometrium that recovered or reached to pregnancy, stage of pregnancy.
Okay, sir. And now over to Dr.
Sharmin,
Asim, because yes,
Sharmin, I have
Madam.
one question.
yes,
Yes,
madam.
madam.
Sure.
Professor Gulshan, yes.
Dr. Mounir, thank you very much for your nice.
Thank you.
I think, madam, your network is troubling. I think, Dr. Asim, you should proceed because we have running short of our time.
Okay. Thank you. Dr. Mounir,
Yes.
you are most welcome in
Thank you.
our country and among us. So you are the inspiration of many of our young gynecologists. So you are doing at so early ages, and you have
Dr.
proved
Asim,
yourself.
our
Yes.
Secretary General, Professor Samsad Jahan Sheli, Madam, joined from
Yeah.
from Hajj. Madam, can you
Yeah.
take 1 or 2 words from you because you are in hurry, I know. Sheli, Madam, would you please
Sheli
unmute
madam.
yourself?
Yes.
Professor Sheli, Madam.
Assalamu alaikum to everybody.
Yes, madam.
I
Yes,
am
madam.
We
from
know you are
Medina.
in Hajj, performing Hajj.
Yeah.
Pray for all of us, madam.
Salam to all. I am going to Asr Salah, Maghrib Salah. So I can continue. And thank you for nice presentation, Dr. Mounir Mostafa. See you, inshallah, in future in our country. Thank you.
Thank you, madam.
Thank you, madam.
Dr.
Now I want to have some questions. So
No,
our
Asim,
young
Asim,
gynecologist. Yes,
Asim.
madam.
As
Madam,
the
please.
patient is under my follow-up, but
Okay,
she
okay.
is suffering from excessive irregular menstruation. And on transvaginal ultrasonography, I have seen that the area from where myoma was removed, that area is still rough and not smooth and not covered by endometrium. So, what will be the next step for management of these cases? Still, she is unmarried, and questions of her reproductive function is also there. So, what management she need?
She needs, I think, a good ultrasound. Okay. Then a hysteroscope to diagnose what is the problem with this area. Maybe there is residual myometrium. Maybe there is fibrosis. Residual myoma. Part of the fibroid is still there, needs to be removed, or there is fibrosis at the area where the myoma was removed. So I will resect the whole area again and leave the area raw for future healing. And yes, when you leave a part of myometrium unopposed or opposed with endometrium, their endometrium will grow in this area.
Okay, several times the TVS is done. So next step is hysteroscopy again, and
Yes.
she may needs resection of that area.
Yes, but you have to know what is wrong with the area first. But most of the treatments will be resection of that area.
Okay. Thank
Thank you,
you.
madam.
Thank you.
Now we are running short of time. So asking questions from
There
our
is a
learned
question here I would
colleagues.
like to answer just first, please. Someone said, can
Many
we
of the
use bipolar with saline? Can we use normal saline with bipolar?
Yeah,
If you are
yeah,
talking
definitely.
about if you are talking about the normal bipolar generator, the ones we have in all OTs, no, you can't use it as bipolar in hysteroscope. This is going to break the instrument. Okay, to break it mechanically because it's very weak current. You need either bipolar under saline generator or monopolar. You don't have the regular bipolar. This device, normal bipolar, we can't use it with hysteroscope.
So many of the questions already answered. This is the one of the video of myomectomy.
Yes.
So part of the video is there. So during resection, sometimes we encounter bleeding. So when we are resected one specimen, the oozing is coming from other sides. So what to do at that period? So should we clean it or diathermy or make it diathermy or any other method to control the bleeding? So when there is a vascularized myoma like that, so bleeding is more, what to do?
This video, this is not vascular myoma. This is you have vessels inside the myoma. You can just hold the cervix. If you have to stop the fluid coming out from the uterus from only 1 minute. For 1 minute, you have to stop the fluid coming from the uterus. If the resectoscope outflow is open, we close the outflow, and I look at the cervix of the uterus. If there is fluid coming from the cervix, I catch the cervix with a tenaculum. I close the cervix. Then you will see the bleeder and you can close it, or you can go on resecting the myoma itself. But there are some times where the myoma is degenerated. The whole thing is bloody sponge. And this time I just stopped because you can never continue. You can never see anything. You can never go in. You open on the myoma. It is now open towards the cavity, and you leave it 1 month. You will go. You'll find it shrinked and much less vasculature. But if you have one bleeder, you have to stop it. But if everything's bleeding, you just go out, and it will stop alone. If you want, in this case, I do this in septum, because in the myoma you have to resect the myoma. In septum, if you have bleeding, you don't want to go like more electricity. So I just go out 2 or 3 more minutes. I do uterine massage, then I go in. I find the bleeder closed.
So can you use balloon tamponade at the time to control the bleeding? Sometimes
The
intrauterine
bleeding will
balloon.
stop in 3 minutes. If you are out, you can use it, but I never saw that you need to use it. If you go out with the resectoscope, 3 minutes, the bleeder will stop, because they are very small vessels. Uterine contraction itself will stop the bleeding, like the postpartum, like after pregnancy. The uterine contraction will stop everything.
Okay. Now, question is then how to select the patient before resectoscope, before resection of submucous fibroid in hysteroscopy. So, is it only the size of the fibroid or anything else we should take into consideration?
The FIGO grade is more important, because
Do
submucous.
you think that other than FIGO, the Lesnar classification will help us? When there is more complexity?
I think it is very difficult to apply it. Okay, it is very difficult to tell me what is the score of this patient for sure, because many times you have an ultrasound report of something, then when you go inside the uterus you find something else. Okay, so I can tell you the Lasmer score after I finish the operation.
Do you think saline infusion sonography will play important role in this thing? Yeah.
Of course, yes.
Of course.
Yes.
Thank you. Another question is.
But here is a point. Wait, here is a point.
Yeah.
If the patient will go for ultrasound saline infusion, this procedure is 99% similar to office hysteroscopy diagnostic. So I would go for office diagnostic hysteroscopy rather than SIS.
No, but thing is that how much myoma is penetrated, how much amount of the fibroid is penetrated into the myoma, it cannot be judged by the hysteroscopy alone. So sonography has its own advantages also. So previous slide, please. So when there is multiple fibroid, especially submucous fibroid, intermural fibroid, and subserous also. So in nulliparous women, what should we do? So do you only from the submucous one, or keeping the intermural and subserous portions as it is, or should we go for both laparoscopy and hysteroscopy?
Nulliparous seeking fertility?
This is nulliparous women. Definitely fertility is an issue.
Yeah, you have it depends on the history. You know, I don't manage infertile patients alone, but I will remove. You have to remove the submucous because of the bleeding. Okay, the question is how to remove this along subserous, subintermural, and submucous. Which to remove first and how? I would go with. I would not go with the same operation submucous and subserosal, because this could cause perforation and weak areas in the uterus. Sometimes I go with hysteroscope first, then I find that most of the intramural myomas, they were submucous. So you removed everything. Other times, if you have big subserosal and intramural myomas, like 7 cm, 6 cm subserosal, intramural, you have to remove them first by laparoscope. Then after 1 or 2 months, you do the hysteroscope for what's inside. So the general approach is to remove all the myomas causing complaint, but you have to tailor what are the steps for every patient.
Thank you. If a patient have intramural fibroid 3.5 centimeter, that is type 4 or type 3, like that, so should we attempt hysteroscopic myomectomy? Because people are asking like that because you are doing some myoma removal by hysteroscopic approach when it is intramural also. So, what's your opinion? Should it be done by hysteroscopically or should be done by laparoscopically?
The problem is FIGO3 myomas are classified as intramural, while in fact they are submucosal. So this is the point. They call it intramural, but in fact it's submucosal. You remove FIGO3 from inside the myometrium, but you don't harm the myometrium. So if it is FIGO3, yes, I have to remove it because it affects the fertility according to literature, and hysteroscopic removal improves the fertility according to literature. But if it's more than FIGO3, no, I will not remove it by hysteroscope.
Because not everyone has that much of expertise to remove the intramural or grade 3 myoma through hysteroscopic approach. I think it needs much more expertise like you. So when you are doing submucous fibroid, so what should be the current settings? So you have mentioned, but if we are using bipolar resectoscopy, as if I am using the Gomini bipolar resectoscope, 18.5 frames, most of the cases. So what should be the current settings? So for coagulation and cutting. So is it different from machine to machine, or it is almost same?
Yes, very good question. But we don't use coagulation. We use only cutting. This is the first thing. So I don't look at the coagulation, and I don't touch the blue foot switch. Only the yellow one.
Yellow one, yeah.
Yes, if you in myoma, in endometrial resection, you don't work with some tissue that you need. Okay, you work with tissues that you don't need. So you have like a margin to increase the power. For monopolar, for monopolar, it's like up to 60. I use 55, 60 watt, and I work freely because in the myoma, all the tissue will come out. In the endometrial section, we don't want all the uterus. But when you work with a septum, you have to decrease the current to avoid damage to the adjacent endometrium. So, so the question was
Bipolar? In
submucous
bipolar?
fibroid. In bipolar, I think it starts from 130, 120 watt, 130. Then I
I
test
usually
because
use 120.
yes,
It's okay.
I don't use this every day. So every time the numbers, I just try. I start 120, 130 and see if I need to increase this. But it's very important because many of the devices around the hospitals, they are not calibrated very well. I don't know if you do this or not. Every 2 or 3 months, the company has to come to the generator. They have to test it. They have to discharge it. There will be inside currents, some current inside and some charges. This changes the readings. They have to calibrate it and discharge it so that after 3-4 months of without maintenance, the 60 watt is not real 60 watt. It's 40 or 50 or 60. It is not real numbers. So you always have to set the number. Then you check the effect. We need smooth cutting without charcoaling, without burning. Okay, so if you need to increase the current or decrease,
that's new to us. So every 3 or 4 months you have to recheck the current settings.
we know it, know it, but we don't do it.
It is better.
we don't do it also. But this is
So
the idea. Sometimes I go places, 90 watt is not working well.
So during resection of the fibroid, so the resected specimens are coming in the field of vision most of the time, and it creates a noise. So how to tackle that resected portions to remove or take away from my vision? And another thing is that sometimes when we are cutting, my instruments is attached with the myoma. So how to avoid this? This is another practical point. So if you enlighten us.
Yes. For the resected specimen, it depends. If you have an anterior or side wall myoma, then the myoma will fall, the cutted part will fall down. Most of the time, they will not make problem for you unless you have a very big myoma. If you have a very big myoma, sometimes you need, as I said, you stop the operation for fluid deficit, to manage the fluid deficit. And when you stop the operation, you go with the open forceps and you get out these parts, and you give methergine or something to contract the uterus to let the other parts, deep parts of the myoma to go inside the cavity. So it's all integrated thing. We do everything in the same time. If you have posterior wall myoma, there's a technique that when you open the resectoscope, you push the resected part and go the myoma and remove one part and push.
When it is attached with the myoma.
Yeah,
sometimes.
if it's attached, it is either a bad loop. The electrode itself is not it's not
Loop
good
electrodes.
metal, or you are using coagulation current, because
No, I'm using the
coagulation
cutting current. Sometimes if I pause the current electrosurgery unit at the middle, then it starts with the
Respected
myoma.
members of the organizing committee of hysteroscopy of Gynecological Endoscopic Society of Bangladesh. Good evening. Actually,
Hello.
Okay.
Sorry.
Yes. What you do if part of the myoma stuck, if part of the tissue stuck to the resectoscope, just open it and go get another part. It will be removed. Let the tissue
Automatically.
push the tissue. Yes.
Thank you.
Thank you.
So next page.
Asim, do you take the important question from Dr. Aisha in the chat box? Dr. Aisha wants to know that if a patient feels severe pain after 2 to 3 days of myomectomy, which not completely remove, what may be the cause and what will be the treatment for her? And after how many days second session should be done?
Yeah. Dr. Mounir.
I think if you don't have complication, if the surgery was good but you didn't make a complete resection, then the parts being expelled from the uterus is the cause of the pain. It is like incomplete abortion, the pain of incomplete abortion with the neurogenic component of cervical dilatation. So I think it's this, because I see it in virgin patients when we don't remove the resected myomas from inside the uterus, they have this complaint. When to make the other set, it depends on how much is left inside, but you can make it after 1 day, 2 days, up to one cycle, 2 cycles. Yeah, this
We are
is
thinking
true.
in resectoscopy, we after Asherman's or separate section, we usually do it after 2 cycles. So
yes,
2 months
in
like that.
Asherman and in septum, you want to check your outcome of the operation. Okay. But in this operation, we are resuming the operation. We were continuing the operation. So what I do is not, I don't wait 2 or 3 days. I wait 10 minutes. That's what I'm saying. Why did the operation was stopped? Mainly because of fluid. So I wait 10 minutes, I get out 1.5 liters of fluid, and I go again as if it's a second set. Okay, so
that is the unique idea we have learned from you in last session. So and it really
last
works.
time you didn't have large myomas.
Okay, okay.
Yeah, this technique is published, by the way, mainly it is published for the endometrial resection. But in fact, you have myomas that needs more work than endometrial resection. So when to have the second set, anytime. You don't have a specific time. But if the
Okay.
patient is in pain, maybe you have to go early. If there is no pain, I usually tell the patient, give me 1 month after the next
Okay.
menstruation.
So next question is, which type of resectoscope should we use if there is large fibroid? So we have already mentioned that largest one should be the
Yes.
best one to do it. So regarding fluid pressure and flow rate, you have already mentioned. And excessive bleeding, yes, we have already answered the questions. So next, next slide, please. So there is always debate between the resectoscope and mechanical tissue table system. So for myomectomy, you are in favor of resectoscopes. But if I ask questions to Bigati, you will definitely in favor of his instruments, mechanical tissue table system. What's the actual scenario? So which should be preferable for myomectomy?
You are the one who has both of them and you use both of them. So you tell me the answer.
No,
Okay.
the thing is that to my opinion, if you allow me, that Bigatti shaver or mechanical tissue retrieval system is a very good system, definitely. So it has very advantage, especially the operative area become very clean and clear. So safety limit
Yes.
is little bit more, but in comparison to resectoscopes. But some limitations is there. It takes much more time. And when the fibrous tissue is more fibrous, there is myoma is more fibrous, or the calcified fibroid is there, then it is very difficult for the uh, Bigatti shaver or mechanical tissue retrieval system to make it out. So in that cases, I think resectoscopes is very good. And resectoscopes has another advantage that it is definitely more quick surgery can be done in resectoscopes, and deeper myoma, especially grade 1 or grade 2, it can be quite easily done by a resectoscope. But
Yes.
for doing that part, you need that much of expertise, and learning curve is little bit more in resectoscopes. So according to size and at the same time the expertise of the surgeon, we should decide which one should be better.
Yes.
Is
Yes.
it okay?
Perfect. This is perfect opinion of an expert surgeon, and very nice surgery is shown here. Okay. And now I will tell you what are the in brief ISGE guidelines for hysteroscopic myomectomy. If you have zero, grade 1 myomas, less than 4 or 3.5 to 4 centimeter, then you use the shavers or mechanical
Yes.
tissue retrieval systems. And probably this is under training, so you don't do it. You give it for a trainee to learn how to use it. Okay, because this is a very simple operation. For FIGO 2 and FIGO 3, you have to use mechanical instruments, then resection. It's not advised to use the bidet. If you have myomas more than 4 centimeter, FIGO 1 or FIGO 0, then you need the resectoscope for the sake of time.
Yeah.
Okay, so the choice is always dependent on what you have, what is the type of the myoma and the size and the depth, and what is your expertise. Okay,
Thank you.
but both devices will do the job when selected and used very well, of course.
Next slide.
But the shaver is very expensive. We have always to say this.
Yeah,
because
yeah, definitely.
I
But
will not
we
buy my
have
car, okay, to make a myoma when you can do it with the resectoscope. You have to say
no,
this.
no, definitely. But we made it make it little bit cost
Yes, but
effective
you don't
one
have to
by
say
our
this.
by our energy system like that. So when we are performing the ablation therapy,
Yes.
so we are facing some problems. So what do you think? What type of ablation is very good or more comfortable. Especially, I can resect the endometrium. I can use my resectoscopes. I can roller ball. I can use the roller ball. I can use the loop electrodes. I can also use the vaporizing needle or electrodes. So
I
which
only,
one
I only, mm,
which one is
I,
better or all are effective?
the resection, this one, the one showed, this is
Yeah,
the best, but the most difficult. Okay.
yeah.
The roller ball is standard. You can't say no for the roller ball. It's much easier. But I usually, especially if there is thick endometrium, I don't think it works very well. After the resection with this resection electrode, I go with the roller ball for areas like the periosteal areas and this. What is the best endometrial resections I do ever is sometimes some doctors I know, before sending the patients, they give them testosterone. This is not right, but they give them testosterone for 1 month, okay? And when you go
Which
inside the
one? Which
cavity,
one they're giving?
testosterone, hormonal
Okay.
to stop the bleeding, but it removes all the endometrium. So when you go inside the cavity, it is very well. It's very nice. You can just do it with the roller ball. You don't need anything because the endometrium is very thin. And once you do it with the roller ball,
They will
everything is done. Yes,
slap out.
but usually these patients, they have bleeding, and if you go without preparation, you have thick endometrium. So you have to go with the resection. You have to remove the full thickness of the endometrium. So if you have the patient well prepared and very thin endometrium, roller ball is very good because it's very easy. Otherwise, you have to do it with the resection, standard resection technique.
What about vaporization?
Uh, I think I didn't use it because I didn't try it in ablation because I think it's very small. It's going to take a very long time. Even the smaller resectoscopes takes very long time. So I didn't try it.
That is not that is appropriate for smaller resectoscopes. They are usually compatible with the larger resectoscopes. So I have used and it is also good. But the TCRE has a special advantage that the resected specimen can be sent for histopathological examination. That is the best way.
If you are talking about the 5 French needle, I know it. If you are talking about something else, you send it to me because I don't know it.
Next slide, please. So already you have mentioned. So the 5 number questions, number 5 questions. Do you expect complete amenorrhea after resection?
90%.
90%. And symptoms
90%
are
of the
removed
patients.
near about 90% or something else?
Yes, 11% of the patients will have a menstruation later. This is the
Do
standard.
you use the Mirena or levonorgestrel using contraceptive? Mirena after the resection? Is it good enough?
I use it in patients who are adenomyotic.
But when there is endometrial abrasion, so one of the contraindication is written that if there is adenomyoma, we should not use the PCRE because main pathology is inside the myometrium. So only the endometrium is removed. So main thing is there. So it is better not to do in adenomyotic uterus.
Yes. Well, we don't do this as a treatment for the adenomyosis, but in patients who are perimenopausal and they have this small, less than 9 centimeter uterus with adenomyosis, I go with endometrial ablation. And when you remove the endometrium, you open more surface to absorb the hormone from the myelina. And now we are working on another thing that you suture the myelina inside the uterus. It's all to try to decrease the need for hysterectomy. But all patients are counseled that this treatment may fail and she may need hysterectomy. Yes, you are right. We don't do resection for adenomyosis. But if the patient has adenomyosis small grade, and you are doing ablation for another reason, then I put the IUD. This is not standard practice.
Okay. So any special preoperative preparation or the timing of the resection to minimize the complication of TCRE? Any special precaution do you have, but do you take
Any
to
special what?
minimize the complication? To minimize the complication of TCRE? Any special preoperative preparation?
Yes,
Do you think that
treatment.
injection vasopressin or something other, some
No,
drugs can be used?
I never tried things that will decrease the improvisation, and I didn't try them. Obviously, they work, but for endometrial resection, it's better to use medications to decrease the thickness of the endometrium, use larger resectoscope, and start with the posterior wall. These three things will make things faster.
Thank you. Next,
Thank you.
next slide, please. Or a few more slides. There is a septum. So this septum we are tackling with scissor. So we can use
Yes.
scissor also. So when there is more fibrous tissue, but sometimes when there is vascularity is more, we can use electrosurgical unit also. My question is there. So for fertility purpose, do you think the scissor is better than using the bipolar electrodes?
There is no evidence on which one is better in the terms of outcome, but there is one study about uterine rupture in pregnancy after hysteroscopic septum repair. They found that the least is with bipolar electrode, not by scissors. Monopolar and scissors, they have higher rate of rupture uterus more than bipolar, probably because of the distal damage we make during resection.
But the question is, when you will conclude that your surgery is enough, so we do not need to go further. When you will, how you will assess that decision? So it's okay. Now we have to stop. How will you decide this? So in ideally, we should have 1.5 centimeter myometrium in the fundus area after the resection of the septum. It says like that. But how we can assess that it is enough?
We have to have 3D vaginal ultrasound with the measurements, and we have to identify what is the length of the septum that needs to be removed. For example, 2 cm, 2.5 centimeter, 3 centimeter, so that inside the cavity, I can measure the amount of the length of the septum I remove, so that I don't go further than the 3D ultrasound. Okay. Then I have the internal landmarks. I have the 2 osteoid. The interosteal line, I should not reach this line. Okay, you have, when you remove the septum, you have to leave a small septum or an arcuate uterus. This is much safer than leaving a defected fundus. Okay,
Do
we
you
also
think
should
that
not forget
paraoperative sonography will help you a lot in that cases, or not needed at all?
during the surgery.
During the surgery,
I
paraoperative
don't use, but
sonography.
yes, if you have a good ultrasonographer
Some
with you and telling you this.
some persons are doing septum resections. In initial stages, they feel that it would be better if I do laparoscopy as well. Do you think that laparoscopy is
No.
at all needed? Or if needed, when?
No, for you don't have indication for laparoscopy unless you have a complication of the surgery.
So
Okay,
do you think that
because
we should counsel the patient before? So when we are using the electrosurgical unit, so you might need laparoscopy.
I don't
You don't
counsel
know.
because it depends on the statistics. How many patients do you need laparoscope when you do 100 hysteroscope?
Yeah, that one person might need laparoscopy. That message can be sent to the patients and her relatives also. Is it okay?
Yes, okay, but you don't have to bother yourself with the patient and argue with her about this. And
That is a for safety concern, and we should have procedure specific consent form for this type of operation.
Okay.
So
Okay.
So next slide. So another question is, when there is septum and polyp, both are present in the same patient, which procedure should we do first? So is it the polyp or septum?
Yes, the polyp. I go for the polyp. Okay, because if you will do the septum with a resectoscope, then before the resectoscope, you have to go, as I said, with the diagnostic with the normal hysteroscope. So with the normal hysteroscope, you use the scissor and remove the polyp. If you remove the septum with the scissors, then the polyp will cause less bleeding than the septum. So you remove the septum, then you go with you remove the polyp, then you go with the septum. But if you remove the septum, then you have a lot of bleeding, then you left the polyp also.
Yeah, and at the same time, fluid absorption should be more when septoplasty is done earlier. So venous sinuses are open, so more chance of fluid absorption also.
Fluid, exactly. Yes.
So for prevention of the postoperative adhesion after septoplasty, what should we do? Do we use the Foley's catheter? Do we use the gel, hyaluronic acid gel, or something else?
I don't have the hyaluronic gel, but if I have it, I will use it. It's not in Egypt available. I stopped using the urinary catheter because I had one patient from UK. She brought with her. She's a doctor and she had Asherman, and she brought with her the hysteroscopic balloon, the original one. Okay, so when I used it, I know why the catheter is not working. The catheter is very useless. If you have a hysteroscopic balloon, this is very good. This is going to work. I give estrogen. This is very important. I give estrogen in adhesions, in septum, and this is the most important thing I do. This is the thing I say to all patients. You have to take the high dose estrogen for at least 20 days or 3 weeks. Sometimes I put IUD after removing the metal.
So in AGL recommendation also, they are not recommending the Foley's catheter or coffee. Only they are doing that is use the high dose estrogen progesterone, or at the same time you can use hyaluronic acid gel. It might help.
There is now something new in China. It's a polymer that is triangular. You put it inside the uterus and you leave it. It disappears after 3 or 4 months. So I think this is going to be a very good idea that you put it once and you leave it. You don't have the risk of infection on this. Still, it's under trials.
It is under trial. Thank you.
Yeah, I can send you the.
We are almost at the end. So next slide, please. So I think you are possibly the highest, one of the highest performing niche surgeon. So we are hysteroscopists. You are the niche specialist, I would rather say. So to you, our colleague said, so should we only remove the inferior part of the Sirenian scar disorder, or inferior and superior part also? And another question is that we are repairing the Sirenian scar defect or disorder in the anterior wall. In any cases, in what circumstances we should remove the posterior part also?
Yes, the main point of the niche repair by hysteroscope is to remove the distal part, which is itself the niche. This is the part that causes retention of the fluid. Okay, while the proximal part doesn't cause, and now most of the people they don't touch the distal part. But you remove the proximal part, you open it, it doesn't. There is no part becomes hidden inside the scar defect, and you have to fumigate all the floor of the niche using the ball electrode. You have to remove the inflammation to make the healing come back. Okay. The state, the chronic of or the chronic state of inflammation is progressive. If you leave the niche today, if you have a niche, after 2 years, the niche is becoming bigger and the inflammation is more, and it could include the posterior wall. So if you find inflammation or a groove in the posterior wall, yes, you have to go and remove it. And this is the new generation of Gobini's surgery. It's called 360-degree channel operation. That means you have to remove all around, because if you remove all the inflammation, you will have healing again. This is the good news about the niche surgery in hysteroscope, that you don't only repair by hysteroscope, but then further healing will occur after this if you did the repair right way.
The thing is that, to me, sometimes I think that whatever we do for hysteroscopic surgery, repair of stomachal or niche, so niche is there only. After the repair, this defect or disorder is still there. So how come? So is it beneficial for the
Yes,
infertility
you
patient,
know,
or
it,
it prevent the Syrian scar ectopic pregnancy if I
you
do
know,
niche surgery in
after,
the
yes, after, after 1 hour, I have a webinar here about this niche. It depends on the definition of the niche. What is the niche for you? In literature, there is conflict between the different definitions. It is the niche was the defect, the hypoechoic area under the scar site on the mucosal side of the uterus. Okay, but the niche here, if you do niche resection, that means the niche is not the defect. What you see by the ultrasound is the defect, not the niche. The niche means symptoms. And now I see
symptoms.
you put in this slide repair of CSDI. Okay, this is you, yes.
Syrian scar
This is
disorder.
yes. Zelenskis disorder means you are updated with the recent consensus. So the recent
Yeah.
consensus says that to diagnose the CSDI, you need a niche plus symptoms. Okay,
Symptoms.
so if you
Yeah.
remove the symptoms and you still have a niche, then this is not CSDI, then you don't need to treat it. So the presence of defect or scar, yes, this is part of the cesarean that you cannot repair. Okay, when you need to repair is when we have cesarean scar disorder. If you have the niche or you have the defect only, you cannot prevent type 1 pregnancy, which is scar pregnancy, an endophytic pregnancy. But you don't have exophytic pregnancy, you have ectopic pregnancy. Okay, if this is the question. So the niche makes ectopic pregnancy, but the scar makes endophytic pregnancy.
Another thing, when the Syrian scar disorder should be tackled by laparoscopy.
If you have residual myometrium below below your cutoff point,
3
I use 3.
millimeter or 2 millimeter?
I use 3 millimeter. You have
3
all the
millimeter.
numbers. I use 3 millimeters.
Thank you.
Thank you.
Next slide. So next slide. Next slide, please. So next one. So next one. Next one. Next one. So it is almost over from my part. So is there any of our learned gynecologist there? So if any other questions you can ask. Otherwise, that would be the end of the session. Before the ending, I would like to invite Dr. Sharmin Abbasi, our Deputy Scientific Secretary, to have concluding message or vote of thanks?
Thank you very much, Dr. Mounir, for the excellent session. Actually, it's a very fruitful session for our mid-level doctor, and our mid-level doctor actually always like your presentation, sir. So we are expecting that you again come, because we have a plan to make a conference on February. So we have a plan. If possible, we can get you, sir. Thank you very much, sir, for give us a concrete message, because by your presentation, we get a very much good take-home message, because you tell us about the appropriate case selection, indication-based use, and perfect use of the preoperative preparation you talk in your presentation, which was very much inspiring for the preparation of the patient. And you also give us the guideline about the choose the right type of resectoscope. This is very much important. We get a very good idea by your presentation. And last of all, you told us about the surgical technique and safety, visualization, and short control stroke, and mindful of fluid deficient limit, because you gave us the calculation, which is very much helpful for our doctors. And last of all, post-operative care and follow-up, and hormonal therapy where needed, and follow-up of the hysteroscopy may be indicated in case of extensive adhesiolysis, fibroid resection, and recurrent pathology. So with your presentation, our doctors get very much good take-home message. So thank you, sir, very much. And my special thanks to GESB. Dr. Asim did a lot for today's session, and Dr. Beauty Rani Roy. Without their support, it is not possible. And Dr. Tanzeem Sabina Chowdhury, our scientific secretary, who gave us a good guideline to manage it. And thank you very much to our scientific partner, Renata, for always supporting us. Thank you and good night.
Thank
Dr.
you
Mounir,
all. Thank you. Yeah.
Dr. Mounir, would you say something?
Yeah, thank you
Last
all.
message to us,
I like
to the young
Dr.
gynecologist or young endoscopic surgeon.
Yes.
Any
I like
message for them?
I like Bangladesh. I like the people of Bangladesh. I have now good friends there. I think that the young doctors in Bangladesh, in contrast to what I see in many countries, they have the support of their teachers and their seniors all the time. Okay, that's why they are lucky. They should stick to you more and learn from their teachers more. And good luck, and see you all soon.
Thank you.
sir.
Thank
Goodbye.
you. Thank you.
Thank you, Dr.
Thanks a ton. Thanks a ton, Dr. Mounir.
Thank you.
Thank you, everybody.
Thank you.
Renata, we can stop the recording and can leave now. Thank you very much.
Thank you, Sharmin.